We are good to go, sir.
Good evening, everyone. Myself, Dr. Raghu, representing from Yashoda Hospital, Malakpet as a HOD. So we welcome to the weekly webinar, which is organized weekly by the Yashoda Hospitals in association with SEMI. And this week we are going to bring about the future in emergency medicine. So future in emergency medicine, the concept of future is likely to involve the hybrid EM concept, combining with the resources of both in-hospital and out-of-hospital treatment. So this involves more of artificial intelligence. So this week I introduce Dr. Sowjanya, who is heading EM at Yashoda Hospitals, Hitec City. She is a known personality. She is National Treasurer for SEMI and Academic Chair for SEMI Board. Over to Sowjanya.
Thank you for the warm introduction, Dr. Raghu. I will be speaking about future care in emergency medicine. So before I talk about future care, I just want to introduce what is our age-old medicine. As we are in an Indian continent, the practice of medicine is very, very old. And yes, as it is represented by Charaka and Shushruta, who has taken the medicine from the concept of Ayurveda. It has been practiced for many, many years ago, which dates back to 6000 BC in India. Since then, the healthcare has seen a lot of revolutions, just like industrial revolution, what we have seen. So in the first revolution of healthcare, it is physician-centric, where all the patient data is managed by the physicians, and slowly it moved to electronic medical records, and but it still continued to be physician-centric up till 2005. And 2005 onwards, we are seeing a healthcare revolution 3.0, which is going to be patient-centric with electronic medical records, which are owned by the patients. And there is an introduction of wearable devices, and telemedicine has come into place. And now the present era from 2016 onwards is more of real-time monitoring of patients, Internet of Things, augmented reality, and artificial intelligence are taking over. So the digital health revolution has been, is amplified to many levels just after the COVID, and it is going to be more of a predictive and preventive healthcare that we are going to see. So as emergency physicians, what is more important for us when the healthcare is revolutionizing in such a fast space? So we as a specialty is a specialty of 21st century. As we know, the specialty has been recognized in India in 2009 and 1968 in recognition has come to the American College of Emergency Physicians. So we as emergency physicians are not trained for one specific disease. We are time-dependent interventionists of acute care and psychological crisis of humans. So we have been successful because of our practice of evidence-based medicine across all specialties. And with the rise of hospital medicine, we have established ourselves as a specialty, and we always take advances, whatever is happening in the field. And we are a specialized workforce, work together to advance the specialty. This made us successful in the emergency medicine. As a result, we have become a bridge between the society and the hospital. So emergency medicine acts as a bridge between the society and the hospital. So whatever is happening in the hospital, advances are known to the society through the emergency medicine. So this is where we hold a great responsibility in taking the future care of emergency medicine. So I give you a small scenario where 87-year-old presents to an ED after sustaining a shock while he was on his morning walk. He has got a CRTD device in situ for the past 5 years, and this is his first episode, which make him panic. So how do you manage this patient? As you know that we will be managing it as per our airway breathing circulation. What else an emergency physician need to know when such patients present to us is interpretation of the data from wearables, which is going to increase exponentially in near future, where everybody, and one more thing what we would see is the increase of geriatric patient visits in the emergency department. As such, geriatric ER is going to be the new norm. 25% of our emergency department visits are going to be of geriatric population who are more than 65-year-old. Because of aging population and medical advances which are increasing age expectancy, this trend is going to increase in future as well. So what is that we have to make ourselves ready is geriatric specific guidelines to manage multiple comorbidities in this population is becoming a new mandate for all our emergency departments. So it helps in improving the patient care and also optimize our hospital resource utilization so that unnecessary admissions can be avoided and those who require admissions can be managed appropriately. So having a geriatric emergency room is going to be a new norm for us in near future. Then wearables are going to increase exponentially. So if you see in the pictures, CRT devices or pacemakers are going to be a new norm to increase the life expectancy of the patients suffering with cardiovascular diseases. Glucose monitoring is another normal thing that we usually use for monitoring blood glucose through an app. Again, all these devices will give us huge amounts of data, and interpretation of this data is a new mandate for emergency physician working in the emergency rooms. So you won't be surprised that there will be a continuous real monitoring of the patients, and those information through cloud will reach either the hospital family or a clinician, and from where the alerts will be generated. So this is what is going to be the new norm, which we have to be prepared for ourselves and take charge of these data, and interpretation of this data will be very, very valuable for us. Then coming to another case scenario, a 45-year-old rescued from accidental drowning while he was on a boating ride in a nearby river. He was unconscious and brought to your ED using a 5G ambulances. This is what is going to be the near future. Already 5G ambulances are available. So what are these 5G connected ambulances? They will have ECG monitors, automatic ventilators, 360-degree camera, which gives us view of the patient while the patient is being transported to emergency room. And they'll have an AR headset where we can guide them for the procedures they can do, and they have a smart traffic control as well. So these ambulances will start the treatment required for the patients even before they reach emergency, and emergency rooms that are going to take these patients are all well aware of what condition the patient is coming, what are the requirements for the patient. So it works both ways. The patient gets the treatment what it is required. ER physician is prepared to receive these patients. So this is going to change our pre-hospital care and take the care to the patient wherever they are. Even if they are en route to the hospital, the care will be provided. Then the patient has cardiac arrest. Initial rhythm was VF and not responded to defibrillation shocks, and 3 shocks has already been given. What's new to manage these patients? So as per 2023 cardiopulmonary resuscitation guidelines, the new things that have come in force from 2023 are eCPR, starting a VA ECMO for these patients who are not responding to 3 defibrillator shocks in the emergency room, and continuing CPR in these patients is a new guideline that has been approved by AHA. The next thing is double sequential defibrillator, keeping 2 defibrillators next to the patient and connecting together and giving a shock one after the other is a new thing has to be implemented for patients with refractory ventricular fibrillation. The other thing is vector change defibrillation, where instead of using only anterior pads, we use anterior and posterior pads and shock the patient, is a new guideline that needs to be followed in these patients. Then how do we prognosticate the patients once they have achieved ROSC? So there are neuroprognostications that are being done. So if the GCS motor score is more than 3 within first 4 days, the patients will have good prognostication, good prognosis. and absence of diffuse restriction on MRI for after within 72 hours or within 7 days will also have a good prognosis. Neurospecific enolase levels less than 17 micrograms within 72 hours will have a good prognosis in these patients. And when you are taking EEG, normal voltage EEG background without any discharges or seizures within 72 hours of ROS, again will have a good prognosis in these patients. So these are the things that need to be monitored in those patients after cardiac arrest and attaining ROS in the ICU. Then your ER is busy and resuscitation bay is full and doctors and nurses are preoccupied, and you have still got 30 patients in the triage area to be seen, and you got a single nurse in the triage area. How do we optimize our resources? This is another challenge that we usually face in the emergency rooms, which are crowded, where the patient care gets affected. So we can always use AI at the triage. So what happens with the AI triage? Once the patient arrives at ED, the triage is done by by an application where it gives you the priority of the patient. Once the values are entered by the nurse, or a biosensor connected to the patient gives the values of the vitals, there is a triage system that gets triggered and gives the triage score of priority 1, 2, or 3. And the nurse has to approve the triage based on the data that he has. If the nurse gives a downgraded triage as 3, it again alerts saying that the application says this is a triage 2, which helps in triaging the patients very faster, and this can be integrated into the EMR system as well. So this kind of a system is not something very far off for us. Even in Hyderabad, few of the EMRs are equipped with this triage system, which is very, very useful. Then monitoring the patients while they are at triage is another useful tool, which helps to triage these patients. And most of the times what emergency room faces is unattended patients in the triage area, or priority 2 and 3 patients, which gets less attention when there is a resuscitation going on in the emergency room, or while transferring the patients to a radiology or other investigations. Monitoring is something that becomes very, very difficult. So AI assisted wireless monitoring is the solution that helps in bridging these gaps in these patients. So patients crash before being seen is another challenge that we face, and the remote patient monitoring system is a solution that we can implement in our emergency rooms, which gets the vital values onto our mobile itself through cloud, and we can always act on these patients even before they crash. Then what are the advantages of these AI monitoring devices or wireless monitoring devices? These can go on to our pre-hospital monitoring ambulances, which transfer the data directly to the physician who is taking care. It can help in monitoring during triage, and quick decisions can be made to decide who has to be seen first in the triage area. And we can always quick onboard these patients to IPDs or ICUs. And not only just limited to the emergency rooms, this can also help in early discharging these patients out of ICU and IPD. And more beds are available for the emergency patients which are going to come to our emergency rooms. And even early discharge can be planned, where patients can be monitored through virtual beds even after they go home. So these are some of the papers that support that SMART is an integrated wireless system for monitoring unattended patients in the emergency room. And the results has been really good, where triaging of these patients can be appropriately done, and sick patients can be seen very early. And this is very useful tool for patients who are waiting in the emergency rooms or patients being observed in the emergency rooms. Then another challenge most of the emergency rooms face is unavailability of IP beds. So virtual wards enabled by technology is another solution that will help in early discharge of patients. Patients can go home safe because they are being monitored by the hospital even after they are getting discharged. Faster recovery happens because they are at the familiar surroundings. Then they can avoid ER visits. If these patients are having any challenges, one of the ER doctors can communicate to them through a virtual visit and avoid an unnecessary ER visits. and avoid hospital readmissions, which is going to be very, very useful in optimizing the resources of the hospitals and reduce recurring healthcare costs to the patients as well. So just by monitoring the patients post-discharge for a week or 14 days are going to be very, very useful. And this is being tried in the cardiovascular diseases where patients are discharged after heart failure are being monitored for 14 days post-discharge. And the results are really, really promising where the hospital readmissions are being avoided by more than 30%, and ventricular arrhythmias, which are malignant, are avoided in 23 to 27% of the cases. So this is how the virtual wards work. A patient is assessed for a home or virtual ward, and this is the model which NHS is following. And if suitable, the patient is cared at home with an aid of treatment plan and a monitoring device. And these patients get monitored 24/7 remotely, and continuous data is sent to the hospital for review. So early warning scores can be developed from the vital data that has been transferred, and community health staff who respond to monitoring alerts. If there are any alerts or EWS alerts are there, they can respond to these alerts and deliver care in line with the treatment plan. If the patient is deteriorating further, the patient can be brought back to emergency room, or if the patient can be observed at home with minimal treatment interventions, that can also be done. And the patients will be discharged from virtual ward once they are well enough. Then another challenge what we face is managing a difficult airway and when there is nobody around to help us. So we have a solution with using robots. Robotic airway robonauts are the ones that can help in airway management when there is a difficult airway. And they also help. The robotics in emergency medicine is very, very useful in doing procedures which are complex and can be done with more precision, and the recoveries are very faster. So robotics in emergency department, just like in other surgical specialties, it helps in performing complex procedures. It does the procedures with more precision and minimal invasiveness, reduce risk of errors during critical procedures, which is very, very crucial for emergency physicians. And it also protects the emergency physicians from exposure to hazardous environments. So these are the common challenges we face, that resident doctor has missed acute stroke in the last night shift. Can we solve these issues? AI can help us in recognizing early strokes and all. AI integrated CT scan readers can help in detecting these early strokes with more precision, and chances of missing these diagnoses can be minimized. Then cardiologist asked for an echo in the last night shift. Is there a way? So the echocardiography machines are coming equipped with AI integrated echo machines will help in giving the required data to the cardiologist. We just have to keep the probe, and how to keep the probe also is decided by the machine, just like how you are seeing in the picture. And once you put the probe in the same direction, it will calculate the measurements that are required for calculating EF and giving the data what is required for the cardiologist, even if the cardiologist is away from the patient. So residents missed sending investigations, which is another common problem we do face when there are junior doctors in the emergency room. So we have softwares that can help in giving clinical decision support systems, just like GLASS. GLASS is a medical specific app that helps in giving. Once you give the history into that, it will help you how to diagnose this patient. What are the decision algorithms that you should be taking, and will guide in cases when it is needed. ChatGPT, I think most of you will be using it for multiple purposes as well. Then training the emergency residents is another challenging thing, because the emergency room is always in high acuity area, and training the residents on procedural skills is very, very difficult on patients. So the solution that comes is using virtual reality and augmented reality, where we can create a lot of simulated scenarios of acute illness or airway scenarios, or code blue scenarios can be created, and we can train the residents using AR and VR. And they can also help in teaching the procedures. If the resident is doing missing out any steps, that can help in guiding them. And virtual reality is another important aspect of emergency training, which we will be using in future. Then there are a lot of operational challenges that we face, like resource planning. We don't know how the emergency room will be, or it's always unpredictable. And crowd management in the ED is another challenge we face. And waiting times, sometimes patients may have to wait for longer times when there is a sick patient in the emergency room. And managing data is another challenging thing. All these can be addressed by using AI and machine learning apps that help in creating smooth workflows for any busy emergency department. So even using an average integrated moving average of emergency department, we can even predict the forecast patient visits in the emergency department, which helps in planning our resources, and other staffing requirements can be planned accordingly. So this is again, can we predict ER visits? Yes, we can predict ER visits using these applications of AI and machine learning. Then this may be the future emergency room with a lot of sensors around and AI and VR tools around. But whatever the future is, how many other technologies that come, we need the human touch. So all this technology, what we use in the emergency room is to increase or augment the human touch, and the time spent by the doctor with the patient has to be increased, so that healing touch will be provided to the patients appropriately, and all the mundane tasks of the documentation and all can be taken care by the technology. So the future care in emergency room will help in enhancing our decision making and streamlining the ER processes, thereby improves our patient outcomes. So the future of emergency medicine care is going to be patient-centric, proactive care, and a predictive care, not instead of a reactive care and preventive care. So what do we need to do for this? Continuous learning is crucial when this medical landscape is changing so rapidly. So we have to embrace curiosity and push boundaries constantly, so that we embrace technology and collaborate with the technology, so that we can use it more usefully, and we should be the forefront of innovation. So, thank you.
Yeah, that is a robust presentation by Dr. Sowjanya. And as we all know this, US spends most of our US spends 18% of their amount of GDP on health, and where the other countries it is double that. And as of now, which has the latest link like a telemedicine, the apps, the drones, and the AI are saving lives in the recent past. And AI is a buzzing adoption of technology which continues to gain the proven care in EM, like triaging, we are seeing it, and any predictive analytics, diagnostic imaging, admin support, and lastly, the most important thing is the triage. Any questions from any side? So what is AI up to now in India? Sowjanya, how far it is developed and what are the future AI in India?
AI in India as such is still in an infant stage,
Okay.
just like how emergency medicine is.
Okay.
Lot of regulatory restrictions has been in place in many countries, because AI still has no clarity how it can be used. It can be used for all useful things and also for derogatory things. So regulatory restrictions is one thing that is stopping India to advance in it. But ICMR recently has released a document for loosening these restrictions and progressing AI in healthcare as such. So there are algorithms that are being developed for clinical decision support, and there are algorithms that are being developed for recognizing ECG patterns. All that has been in place. But when it comes to emergency triaging and all, still it is underway. But few coding applications are available. This is not with artificial intelligence. Below the artificial intelligence, there are some coding algorithms that are available to triage the patients, which is integrated into the EMR. So that many hospitals has started using it, which is very useful for them.
So do we need any separate expenditure to be done to interpret this AI in our emergency department? Do we need any separate software?
Yes.
Do we need any personnel there?
Yes, we we can get our emergency physicians trained once there is applications available. But to get these applications, definitely there is a cost involved as well. So these applications are little expensive to install into organization levels.
As you said in your slide, so the ER physician can cut short the patient visits. So that if it is there, so it can minimize the patient finances. It can avoid unnecessary hospital infections.
Yes.
The nosocomial infections can be cut down there.
Yes. So when we talk about these virtual wards and remote monitoring, these are available. These are not completely AI integrated. These will start streaming the data using cloud technology and all. And lot of companies are available to provide this solution. And this will be the cost to the patient instead of cost to the organizations. That can be tried as a first step. And using these wireless vital monitoring solutions are very, very useful in our emergency rooms as well. So those things can be tried immediately. Virtual ward concept is something that can be tried as well. And some softwares which I have mentioned, like Glass and ChatGPT, are easily available. As of now, it is easily available. That can be tried by our residents, and even we can start trying and see how it is performing.
You mentioned about the SCATE EM triage model. So it is followed, or it is only the app which is mentioned?
That app is available in US as of now. The Kate Triage is available in US, and it is integrated to most of their electronic medical record systems as well. But the triaging system that is available in our EMRs is a coded triage where once we insert our vitals, which is taken by the nurse, it will give a triaging category. So that is what I am saying is available in India. So any other questions?
Any questions from the attendees, participants? I have no questions. Shall we conclude it? So there are no questions. We'll conclude. I thank Dr. Sowjanya for enlightening what is the future in emergency medicine. And I thank SEMI Board, Yashoda Hospitals for bringing every week one interesting topic, which is enriching the students and the faculty, a different knowledge section.
Thank you.
Thank you. Good night.